Regarding cervical spine injury, if I see a patient with cervical spine injury, I'll follow the ATLS protocol and I will immobilize the patient with triple immobilization. Triple immobilization means cervical collar, support on both sides of the cervical spine, as well as spinal board. When I do an X-ray of a cervical spine, I will assess the integrity of soft tissues and bony integrity, and I will classify the fracture later on for the proper treatment. A sub-axial cervical spine scoring system consists of three things. First is morphology. Second is discoligamentous complex, and third is neurological status. Regarding the morphology, it can be scored into no abnormalities, compression fracture, which is code 1, burst fracture, which is code 2, distraction fracture, which is code 3, and rotation or translation fracture, which will score 4. Discoligamentous complex, which is in the posterior aspect, will be either intact, that is 0, indeterminate, that is 1, and disrupted, that is score 2. Regarding the neurological status, the normal neurology is scored as 0. Root injury is classified as given 1 point. Complete cord injury is given 2 points, and incomplete cord injury is given 3 points. Varaco et al. Showed in 2007 that the subaxial cervical spine score of more than 5 should go for operative intervention. Regarding the non-operative treatment, it can be either a Miami J collar or a Philadelphia collar, Hello West, or a Minerva cast if the child is less than 2. CT should be done prior to application of Hello. Regarding the treatment with non-operative management, it can be done for occipital fractures, atlantoaxial injuries, as well as subaxial injuries. Contraindications for Hello are skull fractures, chest injury, old age, that is above 80, and infections. Regarding the application of Hello, for an adult, there are 4 pins to be used. In the kids, we use 6 to 8 pins. The anterior pin is 1 centimeter above the eyebrow, lateral 2/3 of the eyebrows, to avoid supratrochlear, supraorbital nerve, and temporalis muscle. When I'm going to insert the pins, I will ask the patient to flex to close his eyes so the orbicularis oculi muscle is not involved. The posterior side of the pin is by checking the external auditory meatus and marking a line 1 centimeter above the tip of the ear. The complication that it can get loose, it can get infected, it can have supraorbital or supratrochlear nerve injury, it can have abducens nerve injury, which can cause diplopia and dysphagia and dural rupture. Regarding cervical spine dislocation, if there is less than 25% of subluxation, this means it's a unifacetal dislocation. A unifacetal dislocation would have a radiculopathy, and these fractures are difficult to reduce, but once they are reduced, they are stable. More than 25% displacement is a bifacetal dislocation, and spinal cord compression can happen. They mostly involve the superior facets. It's mandatory to do MRIs before proceeding for a reduction of a cervical spine facet dislocation, as the disc is if it prolapsed, and while reducing, the disc can entrap and get extruded towards the spinal cord and cause a neurological deficit. Therefore, no close reduction should be done without an MRI scan. Regarding the close reduction technique, these are indicated for those patients who are awakened, do not have any neurology, and they are cooperative. A patient is placed in the reverse Trendelenburg position. Reverse Trendelenburg means the head is higher than the legs and a Gartner Wang tongs are applied. The application of Gartner Wang tong and its location is important. If you put the pins too anterior, it will have extension moment arm. If it's too posterior, it will have flexion moment arm. When you put the Gartner pins, you will the patient is at risk of temporalis muscle injury or superficial temporal artery and vein. Initially, I'll put 5 kg of weight, and then for every one level, I will add 2 kgs at every 10 minutes interval. Once it's unlocked, I will try to reduce the dislocation. I will stop it if there is worsening of signs and symptoms. Regarding the open retinal fixation, I would do mandatory and MRI scan. All facet dislocation mostly needs a fixation. If there is no disc prolapse, I can go posterior and do the fixation. If there is disc prolapse, I would go anterior first to do the discectomy and then go posterior and do the fixation. Regarding the cervical spine, the spinal cord injury study is called a stasis study. This is called surgical timing in acute spinal cord injury study. It was published in 2012, which showed that a patient who had decompression done within 24 hours experiences grade 2 or more improvement as per Asia scale, compared to only 8% who had delayed treatment. So 20% who had improvement if this was done within 24 hours, and only 8% had improvement if done later on.